Hello everybody, Professor Kirby here. We're going to be talking about CVA today. So objectives, we need to know how to identify the things that can affect blood flow to the brain. We need to be able to describe the risk factors for stroke, compare and contrast the etiology and pathophysiology of ischemic and hemorrhagic strokes and TIA, so you need to understand those and know the difference. Correlate the clinical manifestations of stroke with that underlying pathophysiology. Identify what different tests and studies that we use for patients with stroke. What care, drug therapies, nutritional therapies do we use for stroke patients? What's the nursing management of the patient with the stroke? What kind of rehab care and nursing management are we talking about? What are the impacts of stroke on the psychosocial of the patient? And what sort of EBP implications do we have for stroke? So these are the things that I want you to know after the lecture. A couple of little housekeeping things for you. Number one is that there's a lot of terms and definitions in this lecture. Do yourself a favor, make some flashcards, a cheat sheet, something so that you can study and memorize a lot of these terms and definitions, because they will be easy freebie points for you when it comes to the test and the final. So make sure that you spend some time learning the definitions, because you're going to use them a lot, not only in this class, but going forward in your nursing career, because stroke patients are a very common patient type that you're going to take care of on the med-surg floor. Another thing too is that there's going to be a variety of links and videos in this PowerPoint. Since we are not meeting on campus, and for the sake of time and making sure that those videos play properly, I'm not going to play them during the PowerPoint presentation. So if you go to the Canvas module where you found this lecture, underneath it there's a whole page that's going to have, that does have, the videos and links that are in this PowerPoint presentation. So please go through and watch those, as they are going to supplement this lecture, especially the Code Stroke video. It's a really great video that showcases what happens when a stroke patient gets admitted all the way through their care and discharge. So it's a great video, so make sure you spend some time on that. Okay, so what do we have here? We have a stroke. So it used to be called a brain attack. We've called it CVA, stroke. TIA are some of the terms that we're going to throw around. So what exactly is it? So to define a CVA, it's the sudden loss of brain function, and that's due to the loss or disruption of blood supply to part of the brain, and that disruption of the blood supply results in functional CNS abnormalities. So every year, more than almost 80,000 people in the United States have strokes, and about 610,000 of those are first-time or new strokes. So there's a lot of people having strokes every year. So CVA is a Joint Commission core measure and a national standard of care, which means that there is a specific set of guidelines to how we treat, assess, how we educate patients post-stroke, and the whole goal of that is to improve the quality of stroke patients, and in order to set up some guidelines, basically some rules that we should follow when we're caring for strokes. So this is the blood supply to the brain. So remember that the aorta and the blood vessels that come off of that are the ones that feed the brain and supply blood supply to the brain and the tissues. So any lack of blood supply means a lack of oxygenation to the brain. And a lack of oxygen means death of tissue. And we get functional changes like in thinking, sensation, movement, action, just like a heart attack where time is muscle. In a CVA, time is brain. So remember that time is brain. This is just another visual of the blood flow going to the brain. Okay, so there are two types of strokes. So like I said, time is brain. You can't bring back dead brain tissue. So only 30% of the people who have strokes actually activate the EMS system, which is concerning because once that blood supply is cut off and the brain tissues have died, we can't get that functionality back. So it really needs to be treated as a medical emergency, whether you're a bystander out in the street noticing somebody is having a stroke, or if you are in the hospital and you think your patient has a stroke. So the brain can't store oxygen or glucose, so it needs a constant flow of blood supply. The brain is like a whiny little child. So there are two types of stroke. We have ischemic and hemorrhagic. So let's go ahead and define that. So ischemic stroke is either from a thrombosis or an embolism. So remember, a thrombosis is a form, basically a blood clot that forms in a blood vessel. So some sort of blockage, or an embolism, a blood clot forms somewhere else in the body, breaks loose, and travels to the brain. So ischemic stroke is some sort of blockage or clot, okay? Hemorrhagic, that is either from an aneurysm, which is a weakness in the blood vessels in the brain, and that weakness balloons out on the blood vessel. I have a better picture in a minute, and it fills with blood and can burst. Or from hypertension, which is elevated blood pressure. I like pictures, so there's going to be a lot of pictures. So in our ischemic stroke, we have our clot area there on the left. So something blocked that blood vessel and the blood flow is obstructed. So that basically blood flow is deprived to whatever area that clot is in. Versus hemorrhagic, think of hemorrhage, bleed, which is a bleeding area. So a ruptured blood vessel leaks into the brain and wreaks some havoc. Pathophysiology. So again, make sure that you know the difference between the ischemic and hemorrhagic strokes. So there's a loss of brain function due to the loss or disruption of blood supply to the part of the brain, which then can result in nervous system abnormalities. Those are all the signs and symptoms we see in our stroke patients. So what causes that? What causes these things to happen, or ischemic or hemorrhagic strokes? So for our ischemic strokes, can be from atherosclerosis, which is decreased cerebral perfusion, almost like coronary artery disease in our heart. This is what happens in the brain. There's a hardening and thickening of the vessels in the brain. And when that hardening and thickening happens, then there's a narrowing of the blood vessels and eventually can actually close off and have some issues. So then you can have some ischemia, which is tissue hypoxia, hypoglycemia, and then eventually can turn into a cerebral infarction. So like we talked about, time lost is brain lost. So tissues will die in about 12 minutes. So it's really emergent that this gets taken care of very quickly. Versus a hemorrhagic stroke, a lot of times this is from hypertension, cerebral aneurysms, something that ruptures the blood vessels, and this creates a bleed situation in which there's blood that bleeds into the cerebral tissues, the subarachnoid space, and just wreaks havoc because it puts pressure on the brain, increases ICP, which is intracranial pressure, and we have our tissue anoxia from that. Just another picture showing that. So our ischemic stroke, or our clotting type strokes, Again, can be from a bunch of different things. Risk factors are going to be hypertension. That's the highest risk for both types of strokes, actually. Atherosclerosis, cardiac disease, valvular heart disease, elevated cholesterol, diabetes, poor lifestyle like smoking, a poor diet, obesity, sedentary lifestyle, drugs, oral contraceptives. So you ladies who take birth control, you know, every drug has consequences sometimes, right? TIA is often a precursor, which we'll talk about in a few minutes. Just trying to get my slide to move forward here. Okay, so embolotic stroke. So we're going to discuss this a lot more in our oxygenation content and cardiac diseases, but consider that if the heart is not ejecting the blood from the chambers correctly, then the blood sits, and what is able to form? Well, blood clots, and then they're able to travel to the heart. So clots can travel to the lungs or the brain, and you get an embolotic stroke. Another cause could be heart malfunction or malformations. So I have one of the trainers at the gym that I go to. She was in the middle of a class. She's only 30, and she was training, and all of a sudden she started acting very strange and started having stroke-like symptoms. So they called 911 and took her to the hospital and found out that she had an undiagnosed heart malformation, basically a hole in her heart, which you'll learn about in peds, that created a situation where she had a blood clot form that traveled to her brain and created a stroke at 30. So it does happen. Okay, so our hemorrhagic strokes, remember, are bleeding strokes, and these are often called the arterial blowouts, and causes are hypertension or an aneurysm. So remember that an aneurysm is an artery in the brain that either breaks open after it's like ballooned out, and it can cause bleeding in the brain. This bleeding causes pressure, and that pressure is what causes the brain tissue and death. So it basically squeezes the brain because your skull is a hard shell, and it will not allow the brain to swell. So that's where you get the issues. So one of the hallmarks of this type of stroke is a sudden onset of headache, like the worst headache in your entire life. Does not go away. It feels like your head is going to split open from the pain. That's one of the hallmark signs of that. So you may want to remember that. So the bleeding puts pressure on the brain tissues, which it creates a loss of perfusion, and a loss of blood flow, which has ischemia, which is decreased blood flow, infarction, tissue death, necrosis, and death of those brain tissues. It can happen in any of the layers of the brain: subdural, intracerebral, or epidural. So risk factors. What do you think some risk factors are? Well, TIA is a big one, which is transient ischemic attack, which we'll talk about in detail. So it's often a precursor. So people who are having TIAs or mini strokes are at high risk for stroke, and typically will have a stroke in the next few years. Hypertension is a big one. Atherosclerosis, like we talked about, cardiac disease, AFib, cerebral aneurysm, diabetes mellitus. Just another chart. So if you are in that high risk factor category, they need to talk to their healthcare provider immediately to get a stroke prevention plan. If you're in the caution, then you have several risk factors. You're at higher risk for stroke, but if you make some changes now, get that blood pressure under control, get that AFib under control, quit smoking, try to get that cholesterol down, get that diabetes under control, exercise, get your weight down. So, risk factors again. So make sure you know which ones are modifiable. So what can we modify? Smoking, right? We can quit. So which things can you actually do something about or treat with medications or lifestyle changes? And which ones are you kind of stuck with? So remember, hypertension is the leading risk factor for both types of strokes. Smoking doubles your risk for ischemic strokes and triples your risk for subarachnoid hemorrhage. Diabetes doubles the risk for those who don't have their blood glucose under control. Obesity doubles your risk of stroke. Studies show that 30 minutes of exercise a day can help decrease your risk of stroke. There's a direct link between alcohol abuse and stroke. So lots of teaching points you can do with your patients, okay? Okay, transient ischemic attack, or TIA. So this is a transient loss of blood flow to the brain resulting in temporary neurologic function. And this temporary neurologic dysfunction can last several minutes to 24 hours. Can be precipitated by exertion, standing up too quickly. Usually there's a complete recovery, but it's a warning that there's an impending CVA in the next few years. So the key thing here is that it is temporary and that the patient regains function. So I had a patient whose blood pressure was sky high. I came on shift in the morning. I was trying to get her blood pressure down, give her some oral meds, and then was working on some IV piggyback blood pressure meds. I walk in the room and her son's like, yeah, my mom looks weird. So I look and she's got the classic, droopy face, can't smile, can't speak. She has a lot of the symptoms that we'll talk about later in the presentation about your classic stroke symptoms. So of course I have to treat it like a stroke. So I call Code Stroke. The Code Stroke team comes. We assess her. She definitely has suspected stroke. They send her down to CT to get CTA of her brain. By the time she was done in the scan, they didn't see any evidence of any type of stroke. By the time she got back up to me, she was completely back to normal. Scared me and her son pretty badly. So that was one of my first experiences in the inpatient with a TIA. But no matter what, you have to treat it as a real stroke unless you rule it out. So basically, if the scans come back as that there's no evidence of stroke and the patient regains full function, then it's a TIA. So, signs and symptoms are very similar to regular stroke symptoms, confusion. So a lot of times these patients have atherosclerosis in their carotid arteries, in the arteries in the neck. And so they have decreased blood flow. So if you listen with your stethoscope, you can actually hear a bruit. If you don't know what that is, please look it up, carotid bruit. It's a turbulent blood flow through those carotid arteries that's basically cutting off blood flow to the brain and is causing those TIA symptoms. So you may have some diminished cardiac pulses as well. And a lot of times they will need to go in and do a carotid endarterectomy. There's some videos in the next module that you can watch about a carotid endarterectomy, and that's basically a rotor-rooter plumbing clean out that they do in those carotid arteries to clear out that atherosclerosed tissue and to restore blood flow to the brain before you have total cut off of blood flow. So I'll let you watch those videos on your own. So one thing I want to mention, so I did work on a vascular floor when I worked at UCLA, and I cared for a lot of post-op CEA patients or carotid endarterectomy surgeries. So one thing I want you to think about is if you have a patient who has decreased blood flow to their brain through their carotid arteries, and then you restore that blood flow pretty suddenly with surgery, what sort of things could you see post-op, or what would you be worried about? Well, think about now you have all of this blood flow restored. A lot of times these patients can fall. They get syncope because they stand quickly and they're not used to that restored blood flow, and they actually pass out. Their blood pressure is kind of all over the place as the body is getting used to that new restored blood flow. A lot of times they have headache and they're at risk for restroke because maybe the surgeons didn't get 100% of that atherosclerosed arteries, or maybe a little bit of that tissue could break off and create a clot. So just things to think about. Okay, so there's a variety of different ways to assess stroke. Some of the most common ones are BFAST and the Suddens. They also use this with the lay people, so you'll see them on billboards or you'll see them on commercials to get public awareness of early intervention of stroke symptoms, because time is brain, right? So know the signs of stroke. So balance. Is the person unsteady on their feet? Eyes. Have they lost vision in one or both eyes? Face. Does the person's face look uneven? How do you assess this? You have them smile, and then you'll see a pretty noticeable droop. Arms. So is one arm hanging limp, or it looks like they've forgotten how to use their arm? A lot of times we'll have them put their arm straight out in front of them and close their eyes, and you'll see an arm drift where one arm will not be able to stay up and it'll drift off. Speech. Are they having trouble speaking? So you ask them to say a simple sentence like, "It's a sunny day," or something like that. Time. So this is just meaning that you need to call 911 or call that code stroke if you're in the hospital now, so that we can get them treated, because we'll talk about treatment in a little bit. So I'll let you watch this video. So some hospitals use the Suddens instead of BFAST. And so sudden numbness or weakness of the face, arm, or leg, sudden confusion, trouble speaking or understanding, sudden trouble seeing in one or both eyes, sudden trouble walking, dizziness or loss of balance or coordination, sudden severe headache. So know your facility's stroke assessments. A lot of times you get yearly training on it. They'll give you badge, little cheater guys, so that you know the stroke protocol and how to assess it. And most hospitals have a designated stroke team that you can call if you think your patient is having a suspected stroke. Okay, diagnostics. So when caring for a patient that's having a stroke, it's always ABCs first: airway, breathing, circulation, then history and physical. Level of consciousness, that's LOC. NIH stroke scale, we'll get to that in a minute. And then CT scan. So it needs to be a non-contrast CT scan. Make sure you write that down. Non-contrast CT. That is the way that we diagnose stroke and which type of stroke it is, because depending on if it's ischemic or hemorrhagic is going to affect our treatment options. So it's going to show us if there's a thrombosis or embolism, the hemorrhage, or if there's any cerebral edema. They can also do an MRI or MRA, which is actually going to look at that tissue. They do brain scans. EEG, that's looking for seizures, and that picture to the right is to make sure that sometimes stroke symptoms are actually seizures, so they need to rule out that. Or you could have seizures after your stroke. So we look at different labs like our clotting factors, PT, PTT, and INR, and our H&H and platelets. So these are some examples of what CT and MRI images look like with a CVA. Look closely and see if you can identify the areas there. So there's a special MRI, basically a MRI that looks in those brain arteries. They do use contrast for that, and they look in the blood vessels of the brain, and it can reveal plaque, narrowing, and aneurysms. There's a great video where they show you that, the CT, a live CT with the areas of infarction. So there are several methods that we use in order to assess and measure the stroke signs and symptoms and severity. We have the NIH stroke scale is one of the gold standards that we use and is often put right into the nursing flow sheets. Glasgow Coma Scale and our neurological flow sheet in our electronic health record. So this is an example of what the NIH stroke scale looks like. It used to be back in the day we did paper and you would just check that off. Now it's all in the computer and they just bring that right into the computer. So these are the different areas that are assessed. So they're looking at level of consciousness. They go through the level of consciousness questions, commands. They're looking at gaze, visual fields, facial palsy, that's the drooping. Left arm, right left legs to see if there's any paralysis, limb ataxia, sensory, best language, dysarthria, and extinction. So dysarthria is difficulty with speech. Extinction means neglect, so basically the patient forgets that they have an arm or a leg. You can have limb ataxia, which means no coordination, so this may lead to lack of balance and coordination. So with the stroke scale, a high scale is a poor scale. That means they are having a more severe stroke the higher the number is on that scale. This is just showing different areas of the brain and where it's affected. This is what another scale that they use is the Glasgow Coma Scale. This is a trauma scale. It's a really quick, easy way to use it out in the field a lot of times too, to really quickly assess neurologic function. And it just has a few categories, and the different categories are best eyes open, best verbal response, and best motor response. So even a dead person gets some points. So the best score possible is a 15. That's you and I. We're completely walkie-talkie, no deficits. Even in a person in a coma is a 7. Okay, and depending on how bad they are is how severe. But the stroke scale is used more often. A lot of times the GCS is used in conjunction with it. So this is an example of what a neurological flow sheet might look like. You're going to need to familiarize yourself with your hospital's own stroke sheet. So when you get to clinical, if you happen to have a patient who's post-stroke or your nurse has a patient who's post-stroke, ask them to show you what their flow sheet looks like and what different things that they assess. Okay, so when we're looking at clinical manifestations, it's going to really differ between what side of the brain is affected, our right or left CVAs. So it depends on which artery is affected, which part of the brain is affected. In the elderly, the signs and symptoms might be obvious or they might be subtle. And the severity of the symptoms is really related to where that CVA is occurring and the extent of the damage. So this picture reminds us of the different areas of the brain, structure and function. You might want to brush up on your A and P so that you can understand the consequences of a stroke occurring in different parts of the brain. Okay, so depending on the area of damage is what body side and parts are going to be affected. So with our right brain CVAs, the left side of the body is going to be affected. And in our left brain CVAs, the right side of the body is going to be affected. So when you have a left brain or left hemisphere CVA, again, you're going to have right-sided deficits. Remember, it switches. This is the dominant. So it occurs in about 80% of the stroke population. And this is really going to have issues with language, math, analytic thinking. You're going to have aphasia, which is receptive or expressive. Aphasia is the inability to comprehend or formulate language. You could have agraphia, which is the inability to write. Alexia, inability to read. Acalcula, which is the inability to calculate. A lot of times they're very depressed, cautious, anxious. They're frustrated because they're very aware of their deficits. So they do have a better prognosis for rehab than the other type. So with our right hemisphere strokes, you're going to have left-sided deficits, visual, spatial sense. They're going to be disoriented. They're going to have issues with depth perception. They're unaware of the deficits on that left side, and they often have neglect syndrome where they forget about that side of the body. They're very impulsive and have poor judgment. They're very euphoric, so they're happy-go-lucky, but they can be in denial. So they're a major safety concern. They have a worse prognosis because they're very impulsive and they're high risk for fall and having injuries. So that crossover, so why you have stroke on one side of the brain but you have the symptoms on the other is called decussation. So that crossover occurs inside the brain in the medulla oblongata and the spinal cord. And this is the reason why brain injuries and strokes on one side of the head or brain typically cause paralysis or signs and symptoms on the other side of the body. So our right hemisphere left-sided deficits, again, are going to be have issues with spatial sense. They're very disoriented. They have issues with depth perception. They're unaware of those deficits, very impulsive with safety concerns, and they have a worse prognosis, and they're harder to recover. In our left hemistrokes, which have right-sided deficits, again occur most commonly in more of the critical thinking language side of the brain with aphasia, agraphia, alexia. This is very depressing for the patients because they know the limitations that their body has, but this also makes them a safer patient to rehabilitate in rehab. So, left CVAs have low verbal, high performance, their frustration, their effective rehab, but they're depressed. Our right CVAs have high verbal, low performance. They have more issues with their body, poor judgment, and they're a high risk for injury. Again, just another chart. If you're a visual person, sometimes it's nice to kind of graph them together so that you can figure it out in your brain. Again, so ataxia, there's some terms in here I just want to define. Ataxia is the loss of full control of body movements. Their gait is very unstable and disorganized. Apraxia is the inability to perform particular purposeful movements. Agnosia is the inability to interpret sensations and to recognize things. Aphasia is the loss of ability to understand or express speech. And dysphagia is difficulty or discomfort in swallowing. So that's a big one when it comes to safety too, right? If your patient has dysphagia. Okay, so you can also have manifestations in the patient's vision. So just like how the brain is opposite, so wherever the injury is opposite for the body, it's also opposite for the eyes. So this is called Humannius hemonopsia. It's always a challenge to say that. So basically that's vision cuts. So in your left CVA, you're going to have right vision cuts. In your right CVA, you're going to have left vision cuts. So basically half of the vision is impaired. And this is again because of that crossover that's happening. So this is an example of what a patient might see if they have this particular manifestation in their vision. So imagine having to cross the street with this if you're a post-stroke sufferer. Imagine having to live with half your vision gone. So how, the patient is going to have to scan. You have to teach them to scan because they might miss a car or a motorcycle and get, whacked or any other sort of, they could become injured. So how do you think you should approach this patient? If you're coming into the room and all of a sudden you pop into their visual field, you might scare them. So make sure that you approach from the unaffected side or the good side for safety. Okay, so what sort of nursing assessments do we need to do for a patient who is have had a stroke? So we need to look at their pupils and the shape especially. So we want those pupils to be round. Oval pupils can indicate an increased intracranial pressure. Fixed and dilated pupils indicate severe damage to the brain. So those pupils should react to light and be brisk and consensual. A sluggish response means that there could be increased pressure going on. So we're just trying to be on a lookout for increased intracranial pressure, ICP. So that's basically, again, when the brain is under pressure because of like a hemorrhagic bleed. So signs and symptoms of increased ICP are headache, nausea, vomiting, blood pressure goes sky high, the patient's confused. We see those changes in pupils, fixed and dilated, seizures, loss of consciousness. So this is an emergency. They oftentimes need to relieve that high ICP by drilling holes, burr holes, or doing a craniotomy to relieve the pressure. Okay, so what sort of major functional deficits are we going to see? Well, it really depends on where the damage has occurred. But for motor, you could see hemiparalysis. They could be flaccid, which means they really have no movement. Could affect their bowel and bladder. Dysphagia with swallowing. Their gag reflex is impaired. Gait and coordination could be impaired. Vision and hearing. Neglect syndrome, again, forgetting that they have an arm or a leg. Short-term memory loss. They could have issues with their speech and language and their mood. So they can be emotionally labile, which means they can kind of blow up. They're very frustrated. Again, remember the left CVA is going to underestimate their abilities. They're going to be afraid, depressed. They're going to lack motivation. where the right CVA is going to overestimate their abilities. They're going to be impulsive, and they'll have a decreased attention span. They could have some neglect, and they're at risk for injuries. If we were in class, I would make you do a fun game of charades using all of our terms and definitions, but not this year. Thanks, COVID. Okay, saving the penumbra. So what's the penumbra? The penumbra is the part of the brain, so it's part of the acute ischemic stroke that is at risk for progressing to infarction, but it's still salvageable if they reperfuse it in a timely manner. So if you see in this picture the middle dark circle, that's the infarct. That's dead tissue. Nothing's going to change that. We could revascularize or stop that bleed, and that area is never going to get better. But the area around it, that gray area, that's the penumbra. That means it's heading towards infarction. It's not there yet. If we can intervene quickly and timely, we can restore blood flow, then we can save that area. And the more brain tissue that we save, the better function and recovery the patient's going to have. So our TIAs. So TIAs can almost be considered the equivalent of unstable angina, if you've heard of that for cardiac, with symptoms lasting for a few minutes and then abating. They often have longer duration but they're reversible. And again, they can do things like carotid endarterectomies. They can make a lot of lifestyle changes now before the patient actually has a stroke. So they need to take anticoagulants, lipid lowering agents. They need to get their blood pressure under control and modify their diet. So goals. So with our ischemic stroke, remember those are the clotting strokes, our goal is to reperfuse the brain tissue. So we need to bust those clots if you have clots or if you're within a time. So we use this medication called TPA, which is a clot buster. We can use that within 3 hours. So in this type of stroke, we want to keep the blood pressure somewhat high. And we want to give antihypertensives. Our goal, our systolic blood pressures, we want to keep it about 140 to 150. Where our hemorrhagic strokes, remember those are our bleeding strokes, we want to plug the leak. We want to watch out for that ICP. We want to keep the blood pressure moderately low, less than 140 over 90, and we want to check our clotting times. So with our ischemic strokes, we can give TPA. It needs to be given within 3 hours of the onset of stroke, and can sometimes be given. The American Heart Association has said that we can now give it up to 4.5 hours after the onset of stroke in certain populations. So the goal is to get that CT scan as soon as possible. So to get them to CT and have it read within 20 minutes and try to get that TPA on board within 60 minutes of the patient being in the hospital. Now, what if the stroke was unwitnessed? Husband goes to garden, wife goes to get him for lunch, finds him with stroke symptoms, calls 911. When was the last known well? So we don't know when the symptoms started, so you have to go based on the last time that he was known to be well, last known well, or when he was last known to be normal. That's when the clock is going to start. So knowing when the strokes started is very important. So again, with the TPA, it can be given within 3 to 4.5 hours of the onset of stroke. There are some risk factors with it, and those include brain bleeds, GI bleeds, death. But it can turn you around. My friend who I was telling you about who had the blood clot, they gave her TPA. She has just some residual signs and symptoms right now in her left leg that they're rehabbing with PT/OT, and they are confident that she will be back to almost normal. So because of that TPA. So they give the TPA through an IV, or they can thread it right into where the clot is, and they will inject the medication right into the brain in the OR, the cath lab. We need to make sure that we check our clotting labs first, our PT, PTT, and INR. We need to have a baseline clotting factor. We need to give that drug within 3 hours of the first stroke symptoms. We can't give any blood thinners, so heparin, aspirin, things like that, within 24 hours of the TPA administration. Here's some videos on TPA that I will let you watch. This is the inclusion and exclusion criteria. So inclusion criteria, the stroke has to be within 3 hours from the onset of symptoms. Exclusion criteria is if our bleeding coags are out of whack, if they've had heparin or other anticoagulants, if their platelet count is low, if they've had another stroke or head injury in the last few months, major surgery, if their BP is too high, if their neurologic signs and symptoms are improving rapidly, then it's probably a TIA. Their blood glucose is out of whack, if they're having seizures, if they've had a GI bleed or recent MI. Those are all exclusion factors that they cannot get this medication. So if they can't do TPA, there is other options. So the Mercy procedure, that's that corkscrew looking guy. So they thread that in, and it's a mechanical embolus removal in cerebral ischemia. It's also called a reperfusion procedure. So you might see that later, reperfusion procedure. So if they're candidates, then this Mercy procedure reperfuses the brain. So they thread this corkscrew-like device into the clot. They do that under fluoro with contrast in the cath lab. They can also do a carotid angioplasty with stenting, carotid endarterectomy like we talked about for that carotid atherosclerosis. If the patient has an aneurysm, maybe they caught it before it bursts, as a preventative measure, they need to go in and take care of that aneurysm so it doesn't burst, so we don't have a hemorrhagic stroke. So they can go in and coil it, where they fill up that space, or they can clip it. The clipping, unfortunately, requires a craniotomy, so they would need to actually cut a window into the skull to access that area. They'll put that metal clip on there. This is a wonderful video that shows the timeline of a stroke coming in through the ER, so take some time to watch this. It's done in Australia, so some of the terms are a little bit different than we use here, but the treatment and flow is fabulous. I'm missing a page, 1 second. So with ischemic strokes, we need to make sure that we monitor our ICP, that we do our thrombolytic therapy, TPA, anticoagulants. Again, we can do clot retrieval, we can do carotid endarterectomy, angioplasty versus hemorrhagic. We can also do cerebral angioplasty, cranie, the clipping. We need to watch for hydrocephalus and increased ICP. So I mentioned the Joint Commission in the beginning. So they've developed standards to improve the care for stroke patients. So this is actually part of their core measures. So a lot of hospitals adopt this directly. So nursing diagnosis. Ineffective tissue perfusion, cerebral. So other ones, risk for aspiration, impaired swallowing, altered thought process, impaired physical mobility, self-care deficit for sure, risk for impaired skin integrity, urinary incontinence because of the issues with bowel and bladder, risk for injury for sure, and then our fear, anxiety, social isolation. So our nursing goals, we need to prevent deterioration, injury. We need to have adequate cerebral blood flow, trying to maximize functional abilities, purposeful movements, try to get them to accept residual deficits, learn to adapt. It takes months to really know the long-term effects of the stroke and if people are going to fully recover or not. That's really frustrating because people want to know when they're going to get back to normal or what that new normal level is. We don't know. Time will tell. You need to sometimes be creative in how the patients can communicate. So they have these great boards where the patients can, if they have issues speaking, they can point or draw or write in order to express themselves. So interventions. So in the acute phase, which is in the first 72 hours, ABCs. So airway is going to be very important. Keeping that pulse ox up, giving O2, keeping that head of bed up, helping with their airway. Do we need a suction or breathe for them? Vital signs and neuro checks. We need to monitor their fluid and electrolytes. Seizure precautions, so padded bed rails, bed low, meds, variety of medications we're going to give. Keep that blood pressure down. Anticonvulsants, which are seizure meds, antihypertensives. In the rehab phase, that's a little bit more longer term. So dysphagia precautions. So a lot of times they have issues with swallowing and their gag reflex. So you got to keep that head of bed 30 to 45 degrees. That's very important. You have to keep them NPO until they get a swallow eval. So speech and language pathology comes. They do a formal swallow eval to make sure that the patient's safe to eat and drink. And they'll decide maybe they're safe to eat solids but not liquids, so they'll start them on thickened liquids. Make sure that you still really monitor them. Remind them to swallow. Sometimes you can massage their throat as they're trying to swallow, and that will help facilitate food. If they don't pass their swallow eval, then they may need tube feeding. We're going to learn how to do NG tubes later in the class. So again, with the swallow screen, it's a special RN or speech therapist. You want to give them their best chance. So they usually sit the patient up, and they really look for signs of an impaired swallow or gag reflex, like coughing, choking. Their voice has issues, and they assess all those things. If you have an opportunity to watch a swallow eval, please do. This slide just explains why CVA patients need blood thinners, because they're at risk for clots because of all of these different things. They have vessel wall damage, they have venous stasis, and their blood is more coagulable. Sorry. I keep meaning to take that one out because it's very weirdly placed. Okay, so bowel and bladder, they need a laxative regime. You need to make sure you put them on a toileting schedule because they may not know when they need to go to the bathroom. Stool softeners also help prevent straining because If they strain, it actually increases ICP. They may need to be on a formal bladder and bowel training program to help restore that. Skin, they're at big risk for skin breakdown. So frequent turning, need to make sure that you keep that mouth clean. Communication is hard. So what sort of deficits do they have? Speech therapy is going to come and help them. Be patient, speak slowly. Please don't try to finish their sentences. It's very frustrating, especially to well-educated people or people who came from careers in which they talked a lot, to then go from not being able to express themselves. So they can use communication boards. Again, remember to approach from the unaffected visual side. Emotional care. So they're going to have a lot of interdisciplinary people coming to see them. Occupational therapy, physical therapy, speech therapy. Involve the family in the rehab. And they may need some support groups because their life may never be the same again. Movement, so range of motion is going to be very important. How you position them, again, because they may not feel. If they're not positioned well, and could have some skin breakdown and never even know it. So you need to be very careful with how you transfer these people, help them with their ADLs. You want to try to create a situation in which they are independent as much as possible, but they're not getting frustrated. Body mechanics are very important. So when they're getting out of bed or when you're transferring, you need to be very aware of what their strong and weak side is. So strong side always goes first, especially when you're mobilizing them, okay? You don't want to transfer to like a bed and then they can't grab it because you've done it to their weak side. So make sure you know strong side and weak side. So post-CVA patients are at high risk for falls, so prevention is key. So with a cane, if they're having issues walking, they might need a cane for stability. They want to use that cane on the unaffected strong side, okay? So there's 3 stages of recovery. So usually the cerebral edema resolves in about 4 weeks. And the circulation to the ischemia area is restored in about 3 months. And healthy neurons may form and compensate in 6 months. So like I talked about, this timing can be very frustrating for the patients because they don't know whether the damage is permanent and what the new normal is or not. Okay. Since we're not in class, please feel free to send me an email if you have any questions, and I will get back to you as soon as I can to get you guys an answer. Please watch the videos and study terms. Please read the corresponding chapters in the book. So look up the strokes and please read about them in the book. If it's not in the slides, you're not responsible for knowing it. And happy studying. Please let me know if you have any questions. See you guys in lab soon. Stay safe.